Hello, class, and welcome to This Week in Health Psychology. This week we will be exploring psychology and coronary heart disease. So, the term coronary heart disease refers to a disease of the heart involving coronary arteries which are not functioning properly. The most important diseases are angina, acute myocardial infarction, and a myocardial infarction, just for reference, is what we commonly call a heart attack, and sudden cardiac death. All of these forms of coronary heart disease are caused by arteriosclerosis, which involves a narrowing of the arteries due to fatty deposits which obstruct the flow of blood. Angina is a powerful pain in the chest, which sometimes radiates down the left arm. It develops when blood flow to the coronary arteries is restricted to such an extent that the heart muscle is starved of oxygen. An acute myocardial infarction occurs when blood flow is restricted below a threshold level and some heart tissue is destroyed. It also sometimes seems to happen when a blood clot has further restricted blood flow to the heart. Sudden cardiac death typically occurs in patients who have already suffered damage to the heart through previous myocardial infarctions, although it can occur in patients who previously seemed to have a healthy arteries. Now, let's take a look at the prevalence and risk factors of coronary heart disease. Coronary heart disease is responsible for a third of all deaths of men under 65 and 28% of all deaths. It is the leading cause of death in the Western world and accounts for 400 to 300 deaths in men and 2,721 deaths in women per million per year. The highest death rates for coronary heart disease are found in men, and women in the manual classes, the labor force, and men and women of Asian origin. In middle age, the death rate is up to 5 times higher for men than for women. Now, this evens out, however, in old age when coronary heart disease is the leading cause of death for both men and women. Interestingly, women show poorer recovery from myocardial infarction than men in terms of both mood and activity level. Now, many risk factors for coronary heart disease have been identified. Some of these are regarded as non-modifiable, such as education status, social mobility, social class, age, gender, stress reactivity, family history and ethnicity, or modifiable, such as smoking behavior, obesity, sedentary lifestyle, perceived work stress, and personality. However, whether some of the latter can be changed is debatable, simply because of human nature. Now, let's take a look at the beliefs about coronary heart disease. Now, we've previously talked about the kinds of beliefs that people have about their illness, and we've explored how these beliefs may influence the development and progression of the disease. So some research has specifically examined the beliefs that people have about coronary heart disease, with a particular focus on beliefs about causes. For example, French Marteau and their team in the early 2000s explored how members of the general public understand myocardial infarction and differentiated between beliefs about proximal causes that directly cause myocardial infarction and distal causes such as those mediated by other causal factors. The results showed that even though the respondents did not have coronary heart disease, they still had quite complex beliefs about their causes. In particular, the type of work was seen as a distal cause of myocardial infarction, which operated through stress and high blood pressure. Stress was seen to operate via raised blood pressure rather than behavior and genes, and was seen to have a direct effect on coronary heart disease, which was not mediated by any behavioral or physiological processes. Now, this team further explored people's beliefs about myocardial infarction in 12 patients who had had a heart attack, a myocardial infarction. The results showed while people were aware of many possible causes of heart attacks, they tended to focus on a single cause for their myocardial infarction, which was often related to their symptoms. And this was driven by a need to understand why they had had their myocardial infarction now at that particular time, which was further motivated by a desire not to blame themselves or others, while at the same time trying to assert control over having another myocardial infarction in the future. Now, other research has suggested that respondents have identified various causes of, so the belief of smoking and stress, or it's in the family, or the type of work they do, or eating fatty foods, all has been identified as beliefs by sufferers of myocardial infarctions as increasing their risk of experiencing another myocardial infarction. Now let's take a look at the psychological impact of coronary heart disease. So researchers have suggested that the psychological impact of having a myocardial infarction in terms of psychological morbidity and measures of anxiety and depression might be important. So, for example, Lane's research, again in the early 2000s, used a longitudinal design to assess changes in depression and anxiety immediately after a myocardial infarction. So 2 15-day post-myocardial infarction and after 4 and 12 months were examined. The results showed that during hospitalization, 31% of patients reported elevated depression scores and 26% reported elevated anxiety scores. The results also indicated that this increase in psychological morbidity persisted over the year of the study. Now, some researchers also explored whether such changes in psychological morbidity can be modified. For example, Johnston in 1999 evaluated the impact of nurse counselor-led cardiac counseling compared to normal care. And within this study, the results showed that although patients did not show particularly raised levels of anxiety and depression while still in the hospital, those who did not receive counseling showed an increase in these factors following discharge. So counseling seemed to minimize this increase in anxiety and depression. In contrast to the patients, the partners did show very high levels of anxiety and depression while the patients were still in the hospital. And this dropped to normal levels in those that received counseling. So, counseling isn't just beneficial for those patients, but for those associated with the patients in managing their anxiety and helping the individual and the family move on to a healthy way of living, to get back to normal, a healthy normal. So let's take a look at the behavioral risk factors. So predicting changing behavioral risk factors for cardiac heart disease. Cardiac heart disease is strongly linked to a range of risk factors. Some researchers addressed whether these risk factors can be changed. The five main risk factors are smoking, diet, high blood pressure, type A personality, and stress. Let's take a look at smoking. 1 in 4 deaths from cardiac heart disease is thought to have been caused by smoking. Smoking more than 20 cigarettes a day increased the risk of coronary heart disease in middle-aged individuals threefold. In addition, stopping smoking can have the risk of another heart attack in those that have already had one. As far as diet, a diet in particularly cholesterol levels has been implicated in coronary heart disease. It's been suggested that the 20% of the population with the highest cholesterol levels are 3 times more likely to die of heart attack than the 20% with the lowest levels. Cholesterol levels might be determined by the amount of saturated fat consumed, derived mainly from animal fats. Cholesterol reduction can be achieved through a reduction in total fats and saturated fats, an increase in polyunsaturated fats, and an increase in dietary fiber. Now, high blood pressure. High blood pressure is also a risk factor of coronary heart disease, and the higher the blood pressure, the greater the risk. And it's been suggested that a 10 millimeter decrease in a population's average blood pressure could reduce the mortality attributable to heart disease by 30%. Now, blood pressure appears to be related to a multitude of factors such as genetics, obesity, alcohol intake, and salt consumption. Another possible risk factor includes exercise and coffee, alcohol, and soft water consumption. Then there's type A personality and hostility. Type A behavior and its associated characteristics, hostility, is probably the most extensively studied risk factor of coronary heart disease. Support for a relationship between type A behavior and coronary heart disease has been reported by a number of studies. However, research has also reported no relationship between type A behavior and coronary heart disease. So recent research has focused more on hostility, which has been shown to predict stress reactivity and to be linked to the development of coronary heart disease. And then finally, stress. Stress has also been studied extensively as a predictor of coronary heart disease, and research has shown links between stress reactivity and coronary heart disease, life events, stress, and coronary heart disease, and job stress and coronary heart disease. Let's take a look now at the psychology and rehabilitation of coronary heart disease patients. Now, psychology obviously plays a role in the rehabilitation of individuals who have been diagnosed with coronary heart disease in terms of angina, arteriosclerosis, or heart attack. Rehabilitation programs use a range of techniques, including health education, relaxation training, and counseling, and have been developed to encourage coronary heart disease sufferers to modify their risk factors. Research has explored predictors of uptake of rehabilitation programs and whether they can modify factors such as exercise, type A behavior, lifestyle factors, illness cognitions, and stress. as far as predicting the uptake of rehabilitation, although heart attacks or myocardial infarctions is the primary cause of premature mortality in many Western world countries, over 60% of patients will survive their first myocardial infarction. Furthermore, if risk factors can be modified, then the likelihood of a further myocardial infarction can be greatly reduced. So, rehabilitation programs are therefore designed to reduce these risk factors. Now, despite the benefits of rehabilitation, however, many patients fail to attend either some or all of the classes. For example, in a systematic review of the literature, attendance rates across 15 studies varied from 13 to 74%. Although what constitute attendance also varied from missing a few sessions to missing all sessions. So, why do people not turn up if rehabilitation can be effective? Well, Cooper, in a research study in the early 2000s, explored the factors that predicted non-attendance in 15 studies of cardiac rehabilitation involving patients from Europe to the United States, Canada, New Zealand as well, and concluded that non-attenders were more likely to be older, to have lower income and greater deprivation, to deny the severity of the illness, to be less likely to believe that they can influence the outcome of their illness, and to be less likely to perceive that their doctor recommends rehabilitation. Further, women are less likely to be referred for rehabilitation than men, as are the elderly. Now let's take a look at modifying exercise. Now, most rehabilitation programs emphasize the restoration of physical functioning through exercise, with the assumption that physical recovery will in turn promote psychological and social recovery. Now, a meta-analysis on these exercise-based programs have suggested that they may have favorable effects on cardiovascular mortality. However, such meta-analyses are problematic as there is a trend towards publishing positive results, thereby influencing the overall picture. In addition, whether these exercise-based programs influence risk factors other than exercise, such as smoking, diet, and type A behavior, really is questionable. Then there is modifying type A behavior. The Recurrent Coronary Prevention Project was developed by Friedman and his team in an attempt to modify type A behavior. This program was based on the following questions. Can type A behavior even be modified? If so, can such modification reduce the chances of a recurrence of a heart attack? The study involved 1,000 subjects and a 5-year intervention. Subjects had all suffered a heart attack and were allocated to one of 3 groups: cardiology counseling, type A behavior modification, or no treatment. Type A behavior modification involved discussions of the beliefs and values of type A, discussing methods of reducing work demands, relaxation, and education about changing the cognitive framework of the individuals. After 5 years, the results showed that the type A modification group showed a reduced recurrence of heart attacks, suggesting that not only can type A behavior be modified, but that when modified, there may be a reduction of reinfarction. However, the relationship between type A behavior and coronary heart disease is still controversial, with recent discussions suggesting that type A may at times be protective against coronary heart disease. So, the issue is still fairly complicated. Then we take a look at modifying general lifestyle factors. In addition, rehabilitation programs have been developed which focus on modifying other risk factors such as smoking and diet. For example, Van Elderen and their team developed a health education and counseling program for patients with cardiovascular disease after hospitalization, with weekly follow-ups by telephone. 30 coronary heart disease sufferers and their partners were offered the intervention and were compared with a group of 30 control patients who received standard medical care only. The results showed that after 2 months, the patients who had received health education and counseling reported a greater increase in physical activity and a greater decrease in unhealthy eating habits. In addition, within those subjects in the experimental condition receiving the health education and counseling, those whose partners had also participated in the program showed greater involvement in their activity and diet, and, in addition, showed a decrease in their smoking behavior. At 12 months, subjects who had participated in the health education and counseling program maintained their improvement in their eating behavior. So, the authors of this study have concluded that although the study involved only a small number of patients, the results provided some support for including health education and counseling in rehabilitation programs. And then we come to the issue of modifying stress. So, stress management really involves teaching individuals about the theories of stress, encouraging them to be aware of the factors that can trigger stress, and teaching them a range of strategies to reduce stress, such as self-talk, relaxation techniques, and general life management approaches, such as time management and problem solving. Stress management has been used successfully to reduce some of the risk factors of coronary heart disease, including raised blood pressure, blood cholesterol, and the always controversial type A behavior. Now, part of psychology is also about modifying the illness cognitions. So research illustrates that patients' beliefs about their myocardial infarction may relate to health outcomes in terms of attendance at rehabilitation, return to work, and adjustment of behavior. So in line with this, Petrie in the early 2000s developed an intervention designed to change illness cognitions and explored the subsequent impact upon a range of patient outcomes. In particular, the intervention consisted of 3 sessions of about 40 minutes with a psychologist and was designed to address and change patients' beliefs about their myocardial infarction. For session 1, the psychologist gave an explanation about the nature of an myocardial infarction in terms of its symptoms and explored patients' beliefs about the causes of the myocardial infarction. In session 2, the psychologist further explored beliefs about causes, helped the patient to develop a plan to minimize the future risk of their further myocardial infarction, and tried to increase patient control beliefs about their condition. And in the final session, this action plan was reviewed. Concerns about medication were explored, and symptoms that were part of the recovery process, such as breathlessness upon exercise, were distinguished from those that were indicative of further pathology, such as severe chest pain. Throughout the intervention, the information and discussion were targeted to specific beliefs and concerns of the patient. And the results showed that patients who had received the intervention reported more positive views about their myocardial infarction at follow-up in terms of beliefs and consequences, their timeline, their ability to control and cure and symptom distress. In addition, they reported that they were better prepared to leave hospital, return to work at a faster rate, and reported a lower rate of angina symptoms. Now, no differences were found in rehabilitation attendance, and the intervention therefore seemed to change cognitions and improve patients' functional outcomes after the myocardial infarction. So, some final thoughts. Coronary heart disease is a common cause of death in the Western world. And it's fairly clear that psychology has a role to play in this illness in terms of beliefs people have about coronary heart disease, the psychological consequences of a diagnosis, the psychology of the risk factors in the behavior, such as smoking and diet and exercise and type A behavior and stress, and the development and evaluation of those diseases. So it's clear that psychology has a significant role to play in the prevention of coronary heart disease, as well as in the recovery for those with myocardial infarction, to help modify risk factors in individuals who already have the disease. So I think it's an important part of the health psychology role, and I hope you enjoyed this week. I'll see you next week. Bye-bye.